Welcome back, everyone, to our Research Connect series. My name is Jeannie Stumlao, a CDTRP trainee, currently doing a Master of Science program at Simon Fraser University in British Columbia. I will be facilitating today's webinar. First, I would like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saluto, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I would also like to acknowledge that I am privileged to work, live, and play on the unceded traditional Coast Salish lands, including the Tsleil-Waututh, Coquitlam, Squamish, and Musqueam nations on which Simon Fraser University is located. I encourage you to write your land acknowledgements in the chat box. We would also like to acknowledge Estelas, whose generous support we could not have hosted these sessions without. Before we dive into the main content, I pass it on to Erica for some general CDTRP updates.
Thank you, Janice. Today I have two announcements. Firstly, our innovation grant competition is officially open. CDTRP is offering $30,000 in seed funding for innovative pilot projects related to donation and transplantation. If you're interested, you have until April 1st to submit your applications. A link will be in the chat to learn more about this opportunity. Secondly, CDTRP is recruiting pediatric organ and bone marrow transplant recipients and family members or caregivers to participate in a study evaluating the continued impact of COVID-19. If you're interested in learning more or signing up, a link will also be in the chat. That's it for me. Back to you, Janice.
Thank you, Erica. So before I introduce today's speaker, I have a few housekeeping notes. Today's session is recorded and posted on the CDTRP website and YouTube channel. During the presentation, please keep your mics off. If you have a question or comment, you can raise your hand with the raise hand button or type it in the comment section. I am pleased to introduce our first presentation in our new 5-part series, Annual Scientific Meeting, We Are Not Done Yet. Today's speaker, Dr. Emmanuel Bebawi, holds both a Doctor of Pharmacy and a Doctor of Medicine from the University of Montreal, where he graduated with distinction and completed his training in internal medicine. Currently a cardiology resident, Dr. Bebawi brings valuable expertise from his previous work as a hospital pharmacist, specializing in cardiology and heart failure. His research focuses on advanced heart failure and heart transplantation in collaboration with the Montreal Heart Institute to drive advancements in this critical field. Dr. Bebawi, I will now hand it over to you.
Thank you very much. I will be sharing my slides. There we go. All right. So thanks again for having me today. I will have the pleasure of discussing work that we've done with the Advanced Heart Failure team at the Montreal Heart Institute, which concerns weight-adjusted dosing of rapid anti-Thymocyte Globulin in heart transplantation, impact on outcomes. All right. So I have no conflicts of interest for this talk. The learning objectives of this presentation is first to review rapidly what the heart transplantation guidelines say about this particular drug, the RATG, as the acronym I'm going to use for the presentation. Explain RATG's role in prevention of acute rejection during heart transplantation, determining the optimal dose, which is kind of the bulk of the presentation, and explore the clinical outcomes related to RATG dosing strategies. So RATG is basically an antibody that's derived from rabbit, or it could be from horse, but in our current talk, it's going to be derived from rabbits. And essentially, to make it simply, it really just depletes your T cells to permit intense immunosuppression and decrease the risks of rejection when you're transplanting an organ. In this scenario, we're talking about the heart. And when we give the RATG, we really can appreciate a depletion of T cells, specifically CD3s and CD2s, in a very profound manner. And it's a lot, and it lasts more than a couple of days. It can go up to about a year until you really start recuperating your levels of CD3, CD2s. So a little bit of context. When we talk about advanced heart failure, usually there's obviously medical therapy, mechanical support, but really the mainstay or the best treatment that you could offer a patient if he qualifies is a heart transplant. And with time, we've become very good at heart transplantation, and we've made it like perfected techniques and perfected medical therapy around heart transplantation. That now 1 year survival is approaching 95%, and median survival in North America is greater than 12 years. However, although we have a lot of advancements in the field, it's still not clear what the goal or the role of induction therapy is, in the sense that yes, we know that it will provide intense immunosuppression, and yes, we decrease the risk of allograft rejection. But when we look around of what's going on worldwide, half of the programs don't utilize induction therapy at all, and it's still a point of controversy within the community. And what we know is that you're always trying to balance the benefits versus the risk. So the benefit, at least the main benefit you're looking for, is to reduce the chances of having an early rejection of your graft, specifically when you're talking about heart. Patients can get very sick when they have an acute rejection. But the harm of the profound immunosuppression comes from infection, and the big worry is the long-term risk of malignancy. And when you look at what the guidelines say, is that the ISHLT guidelines, they'll say that induction therapy with anti-Thymocyte globulin is reasonable for patients with isohematoglutinin titers 1/8, or if you have other risk factors. That's verbatim what they say. It's a class 2A, but level of evidence C. So again, there's not a lot of good evidence to support its use, but it's because there's a lack of evidence. And it also says that immunosuppressive induction with ATG may be beneficial in patients at high risk of acute rejection. Again, class 2B recommendation level of evidence, that is C. When you look at the data that's available, it really derives a lot from observational studies. And what the studies say is that usually you'll be able to decrease the chances of having acute rejection. So patients that don't have induction therapy compared to those that do tend to have more acute rejection. And there's also a small signal in the literature that says that maybe you have a higher incidence of malignancy-related deaths for people or patients who have used ATG as induction therapy. And when you look at randomized controlled trials, there's no really recent trials that have been done on the matter, and the ones that have been done in the past are usually of small size and often underpowered. So the guidelines say that, for patients who are allosensitized, specifically if you have a positive cross match, you should consider really induction therapy with either anti-Thymocyte Globulin or barzolvolimab, which is an anti-interleukin 2. But the molecule that really interests us here today is the anti-Thymocyte Globulin. And when you look at who are the patients that we would consider high risk of important rejection, it's usually younger patients, African Americans. We're looking at patients with high number of HLA mismatches, and patients who've been supported with ventricular assist devices with high levels of preformed antibodies. So who do we really want to administer our ATG, or patients who are at high risk of acute rejection? But also for us in the heart failure field, it's really to delay the initiation of our nephrotoxic immunosuppressive drugs like cyclosporin or tacrolimus. And the reason is that when you have advanced heart failure, you usually have concomitantly some form of kidney injury. If graft has to be done for fulminating, let's say myocarditis, patients can be in an acute kidney injury, and then you're kind of stuck with that. Patients can develop acute kidney injury following the surgery and will need temporarily some dialysis. So the RATG for us at the Montreal Heart Institute, why we tend to give it for most of our patients, to not say almost all of our patients, is yes, to reduce the risk of acute rejection, but also it helps us to have a bit of a buffer zone where we can let the kidneys recuperate before we instill the other, like our maintenance immunosuppressive drugs that can be nephrotoxic. The last advantage of RATG induction is that you have a bit more flexibility in terms of glucocorticosteroid weaning, and it really allows you to have maybe a more rapid weaning of the glucocorticosteroids. So in Canada, when you look at what's done in Canada, when we speak with our colleagues from across the country, most centers in Canada that do heart transplant will use RATG induction. But again, the protocols that are used are very, very, very different from center to center, and I would even say from individual doctor. Also, sometimes it could vary. Why? Because again, we don't have good data to guide us into what's the dose, what's the regimen that we should be giving. And like I said, here at the Montreal Heart Institute, we use a fixed dose of our ATG for the vast majority of our patients. So the objective of our study is really it's really aimed at saying what's the weight, like the best dose in terms of weight adjusted dose of RATG we can give for heart transplant induction therapy. And this comes from a discussion with the Montreal Heart Institute pharmacists, who are very good and had the insight to tell us that maybe a fixed dose for everybody is not the best way to approach the induction therapy, but maybe try to personalize it a little bit more to the weight of the patient. And that's where that study came from. The study came from a need to really have a better regimen for our patients. So what we decided to do is we did a retrospective analysis, and we took all of our primary isolated heart transplant patients who received RATG induction, which gave us about 340 patients. And we went into our database retrospectively, and we took patients from January 1983 to June 2018. Patients who died during surgery were excluded because those are not the patients we'd want to evaluate, in the sense that the death is probably not due to the induction therapy, but to complications related to the actual surgery and the transplant. What we currently do is we give 3 doses of 125 milligrams. So patients end up with a total of 375 milligrams of RITG on 3 days, separated in 3 days. And very rarely do patients get a bit of modulation of the dose. Obviously, clinicians on the ward can decide to change a bit the regimen if there's worry or issues clinically or due to the laboratory parameters. But the vast majority of patients, as I will display it later on, really receive the 325 milligram doses. And then we decided to separate, again, retrospectively, patients in 3 groups according to the weight adjusted dose cumulatively. So we looked at so we did 3 groups. So a group that received less than 4.5 milligram per kilo. Then the second groups were patients who received between 4.5 to 7.5 milligram per kilo. And the last group was over 7.5 milligram per kilo. And that was like their total doses. So that's how we kind of separated the patients. All patients received their triple immunosuppressive regimen, which comprised of corticosteroids, an anti-proliferative agent, and a calcineurin inhibitor. Sirolimus could have been used for patients who had allograft vasculopathy, cardiac allograft vasculopathy, or who were later diagnosed with CAV later in the follow-up. And since 1998, statins and aspirin were initiated early post-transplantation, irrespective of the CAV status. And from March 1st, 2010, corticosteroids were tapered within 6 to 12 months post heart transplant, unless there was issues with rejection or patients who are really high risk features of acute rejection. Our composite endpoint was, so we decided to do a composite endpoint to kind of see, based on the cumulative weight, based on the cumulative weight adjusted dose, what's the dose that offers the best balance. So that's something that hasn't been done often in the literature in this topic. And what we decided to include is death, acute rejections, and infections. And our secondary outcomes was to take each component of the composite endpoint separated in different endpoints. And we looked at the full follow-up, so full follow-up for all our patients, and at 24 months. And the rationale to look at the endpoints at 24 months was that we knew that the follow-up would be different between the different dosing groups. So by looking at 24 months, we're kind of evaluating patients at the same timeline, but also we suspect that the bulk of the effect of our ATG should be seen within the first 24 months. And then as you go further down in the time in your follow-up, maybe there's other factors that could explain the development of endpoints, but we still feel that you should we need to look at the full follow-up, because there's very, very little data that really evaluates the impact of induction therapy in the long term. So we decided to have kind of best of both worlds, looking at the long-term impact, but also looking at 24 months, which we suspect to be the bulk of the effect of the induction therapy if there was any adverse events from that therapy. Then we also looked at causes of death, malignancy, and CAV. And we did, in terms of our statistical analysis, we reported as absolute incidences. And we looked at the endpoints as well on Kaplan-Meier curves. And we did a univariate multivariate Cox regression and a ROC curve analysis that I'll be showing you later on. So let's look at the result. So our cohort, again, separated into the three different weight-based dosing groups. We had 69 patients in Group A, 245 in Group B, 26 patients in Group C. And we see that the vast majority of patients were male, specifically in Group A and Group B. But in Group C, there was more women than male, which could be understandable because, again, we're separating the dose based on their weight. So women weighing generally less than men would make Group C have a bit more women than men. That's what explains this difference here. The vast majority of patients were of Caucasian, or should I say white, and this is representative of the transplant population in Canada. But there is a lack of diversity here in our cohort. In terms of the immunological risk, there's not a lot of differences at all between the groups. And then when we look at the era of transplantation, again, it's evenly distributed across the different eras of transplantation and within our three groups. When we look now at comorbidities, what really stood out to us is that Group A really has a cluster of metabolic factors. So there was more diabetes in Group A in proportion to the other groups. There was more dyslipidemia. They had a higher BMI, which is expected because we're taking their cumulative dose divided by the weight, and more smoking history. So we could conclude here that Group A has a, I wouldn't say necessarily sicker, but they seem to be more sick in terms of their metabolic risk factors. And for the CMV serolytic status mismatch, it was equivalent across the three groups. There's a bit of discrepancy in terms of their drugs at discharge. We can see that the cyclosporin spread is not quite equivalent, and same for the corticosteroids. So when we look at our follow-up, Group A had a mean follow-up of 107 months, Group B 134 months, and Group C at 69 months. But when we look also at how many patients received the full dose, so the full 3 doses of 125 milligrams, 96% of our cohort received the full induction dose. So this kind of tells us that we can kind of isolate the dosing effect here, which seems to be quite stable in time, and then try to see what the endpoints will be according to the exposure of the dose. So let's look at our endpoints. So for the primary composite endpoint, when we look at the absolute incidence, Group A seemed to have less of the primary composite endpoint, with infections being lower and infections driving probably that endpoint. So what we see here is that people who had less than 4.5 milligram per kilo of RATG on the full follow-up, so the whole follow-up, they seem to have less infection in terms of when we report as an absolute incidence. And when we look at the same endpoints at 24 months, what we see is we don't really see a difference for the primary composite endpoint in terms of the absolute incidence, but Group B, 4.5 to 7.5 milligram per kilo, seem to have less deaths. And the difference here was compared to Group C for the statistical significance. And when we look for infections, again, we see that Group A had the lower incidence of infection. So essentially lower our ATG dosing in absolute incidence for our cohort at full follow-up, and at 24 months, we seem to have way less infections. Group B, sorry, seems to have a benefit in terms of mortality at 24 months. When we look at the Kaplan-Meier curves, we don't have a correspondence of statistical significance on our Kaplan-Meier curves when we look at it at full follow-up. What's really intriguing to us was when you look even just for the primary composite endpoint is the events happen really rapidly and really early for all three groups, which could explain that we don't really see a statistical significance. But we could see that Group C, almost all of the cohort ended up having an event. So it really happens really early post transplant. But we see here that for infections, it kind and for the full follow-up, it kind of the curves seem to mingle a little bit, and the same for death. When we look, however, the Kaplan-Meier curves for 24 months, what we see is, yes, the primary composite endpoint was not statistically significant, but there seems to be a difference picked up on our statistical analysis here between Group B, which was the intermediate dose, so 4.5 to 7.5 compared to Group C, and that was statistically significant. And when we look at the survival in terms of time to death, the Kaplan-Meier is in agreement with the absolute incidence, showing that Group B seemed to have better survival than Group C at 24 months. Yeah, and if we look at for time to rejection, there's not really any difference between. We don't seem to pick up any more acute rejection from having a lower dose compared to a higher dose in the absolute incidence and on our Kaplan-Meier curve. So we don't seem to pick up on higher rejections, even if we lower the dose of our ATG. When we look at CAV and malignancy, there was no statistical significance associated with all groups. Just a little caveat, Group C seemed to have a lot of events really rapidly, and there was a relatively good amount of deaths. So it's to wonder if we would have seen more neoplasia if they would have had survived longer. But that's the data that we have for now. We can't say that we've picked up on a signal of higher cancer based on higher dosing, or we've decreased cancer with lower dosing. And we decided to do a ROC curve analysis to try to estimate the dose. And this has not been done to our knowledge before in the literature in terms of RATG dosing. And the optimal dose for the risk of developing the primary composite endpoint at full follow-up is 4.44 milligram per kilo, with an area under the curve of 0.706, which was statistically significant with a sensitivity of 58.8 and a specificity of 84.5%. And when we look at our univariate and multivariate Cox regression analysis, we pick up on the era of transplant that seems to be associated with the risk. The use of calcineurin inhibitors is associated, and or antimetabolites. And when we look into the multivariate, we forced the component of RATG dosing, and it seems to have an influence in terms of risk of developing the primary composite endpoint. And then when we look at the era of transplant, having the latest era of transplant is more protective than the later, so it means that's probably just a reflection of just our better care generally in the developments that have been done in heart transplant. So that makes a lot of sense. And when we look for the calcineurin inhibitors, what we see is that the presence of tacrolimus and the absence of cyclosporin seems to offer more protection as opposed to the presence of calcineurin and the absence of tacrolimus or not having any calcineurin inhibitor. So that also makes sense. Our antimetabolites ended up not being statistically significant in our multivariate analysis. And also the presence, so it's so this is the absence of sirolimus. So if you have presence of sirolimus, you're more at risk of developing the primary composite endpoint. So what do we do with all this in terms of the current literature? How do our results fit? So what our results really contribute is that, one, we examine the intermediate and the long-term outcomes. Very little studies have really given us long-term outcomes in just period. There's one study that we will show later on that has done that. But even when we look at randomized controlled trials, they're usually not that long in terms of duration. So we contribute to that. But also it's looking at the intermediate, so at 24 months, which is probably where most of the events that had to occur that are secondary to the induction therapy will happen. So we're basically looking at both, and that's something that hasn't been done before. And to our knowledge, it's the first time that we use a ROC curve to try to really estimate what's the best possible dose of RATG that we can give for our patients. Again, it's a retrospective analysis. You have to keep that in mind, but it's still interesting to have an estimation of the dose. And the fact that we had a fixed dose, this is not done by design. It's just that we haven't really refined our therapies through time. But the fact that our dose is fixed, it allows for a retrospective calculation of a weight adjusted dose, minimizing the bias of practice changes over time. While other studies, like the Ali Abadi study that I will present later, tended to adjust through time their RATG doses based on the trend of wanting to go with lower doses. So us having a fixed dose kind of removes that variable in when we interpret our data. So the two other studies that I think are comparable to ours that complement each other is the Ali Abadi and al that was done in 2016 and Lee and al that was done in 2022. So Ali Abadi and al used the same dosing range that we did, and that's we chose those doses specifically to be compared between each other based on just previous data. Lee and al is a center in Washington that already had the insight to go with lower doses, so they wanted to compare 4.5 and under 4.5 milligram per kilo of RATG. And it was only a 2-year duration study, and Ali Abadi and all did a full follow-up like us. When we look at the primary composite endpoint, the dose that seems to have benefited the most at full follow-up is the dose that was under 4.5 milligram per kilo. While Ali Abadi and all, the dose that seemed to have the best overall protection, let's say, due to induction therapy was the 4.5 to 7.5. And Lee and al did not evaluate a composite endpoint. When we look at mortality, Ali Abadi and al did not find any difference in terms of mortality. In terms of Lee and al, they found that 4.5 milligram per kilo had maybe a bit better results. But when they decided to do analysis looking at 1 month survival, there was no difference between the groups. And when you look at our data supports that maybe 4.5 to 7.5 milligram per kilo, as opposed to a higher dosing of over 7.5 milligram per kilo, seemed to have better mortality benefit at 24 months. And it was statistically significant on the absolute incidence and on the Kaplan-Meier curve. When you look now at infections, no difference in terms of infections for Lee al. For Ali Abadi al, again, the 4.5 to 7.5 milligram per kilo group seemed to have the best benefit in terms of lower infections. But in our study, our analysis, it's the under than 4.5 milligram per kilo per milligram per kilo group that seemed to have the best benefit, which makes sense. That's saying that you give less immunosuppression, you should have less infections. Ali Abadi and all justified that it was the mid group, saying that the under than 4.5 milligram per kilo maybe had more acute rejection and needed more intensification of immunosuppression later on, and that's why that group ended up having more infections. And when you look at acute rejection, there's no difference, surprisingly, in terms of acute rejections within the 3 different studies. When we look at it. So what's the optimal dose? So that's what we want to answer today. And our study, based on the ROC curve analysis, is 4.44 for long-term outcomes. Ali Abadi al seem to have the best overall benefit at 4.5 to 7.5 milligram per kilo. And for Lee and all, there was no difference between 4.5 and less than 4.5 and 4.5 milligram per kilo. So the answer is, what would be the best dose? And when we take all 3 studies and including our results, the common factor would be, I think, 4.5. 4.44 is not really far from 4.5 milligram per kilo. So I think that 4.5 milligram per kilo, when we look at just the overall of what we've done and what's done before, seems to be the sweet spot in terms of dosing for RATG and heart transplants. To kind of wrap it up, our study here has some limits though, so everything that we've discussed here needs to be put into context. First and foremost, it's a retrospective design, so it comes with its inherent biases. The other thing that was kind of that we have to point out is that the absolute incidence rates were, yes, positive, but when you look at the Kaplan-Meier, they weren't. And what we look at also is that we had a lot of events. So you have a high number of subjects developing the primary endpoint, few without. So when you look at then, let's say, malignancy, well, maybe patients don't survive long enough to develop malignancy, and we can't answer that to answer if that's an issue in our cohort or not. Also, we have an unequal sample size across the three groups, but that's due to the retrospective design. And Group C was a relatively small group compared to the other groups, which with our statistical analysis often was the Group B that was compared to generating, let's say, the statistical significance compared to A or to Group C. Again, we spoke about it, the Kaplan-Meier not necessarily showing a corresponding significance to absolute incidence, but this could in part be also explained by one, Group C being a relatively small group, but also by the fact that the endpoints, like I pointed out earlier, happened so fast in such a short time frame that maybe when you put the factor time of the Kaplan-Meier analysis, the statistical model has a hard time detecting a difference. So in absolute incidents, you could have a difference, but when you add the factor time, maybe you're not able to pick up that difference. And again, our cohort lacked a diversity with majority of patients being males and white, but that seems to be the overall heart transplant population in Canada. But despite all these limitations, when you look at our findings, they're not far off from what's been done previously. And I think that based on everything, we could say that the optimal dose for now seems to be 4.5 milligram per kilo in heart transplantation. And it seems to be the induction dose that gives us really the best overall protection if you're a center that uses our ATG. And the benefit probably comes from the fact that we're reducing the amount of infectious complications, specifically in the first 24 months. And we don't seem to have a signal of necessarily increased acute rejection by lowering the RATG dose. But again, these data have to be evaluated prospectively. And the other thing, someone could make an argument saying that maybe it's just that weight is a sign of frailty. So weight probably has a bit of an impact here, which would make prospective studies very interesting. As people who are of lower weight probably have a higher cumulative RATG dosing if you're giving them a fixed dose, but weight seems to be a sign of frailty in heart transplantation. So prospective studies are really needed to evaluate this. I don't know if there's any questions and relate to the talk.
So thank you for that excellent presentation, Dr. Bebawi. So yeah, we'll open up the floor for any questions. And if you want, you can raise your hand or type your question in the chat. I'll keep an eye on that. I guess I could start off with the first question. So how does RATG compare to other heart induction therapies in heart transplantation?
So it's usually the two that are compared is RTG with the baxiliximab and the anti-EL2 inhibitor. The anti-EL2 inhibitor from memory seems to have a little bit less infectious complications, but RTG seems to have a better survival benefit. So RTG seems to be maybe the better choice in terms of mortality, but again, the studies are very small, so it's hard to say with certainty that one is better than the other. But I would say that RTG would be a better option for induction if you want a better immunosuppression, and I think also you have less acute rejections compared to the anti-EL2 inhibitors.
I have a question. You mentioned that this is a limited study based on comparing three other studies. What further research would be needed to definitely establish an optimal RATG dosing?
Well, I think there's a two-way to answer that question. The first part is do we just evaluate the impact of induction therapy versus no induction therapy on hard clinical outcomes? That would be the first step. And then the second step would be to prospectively evaluate RATG at 4.5 versus 4.5 to 7.5 and over 7.5. So it would need to be done more prospectively. But again, these studies I would assume are very hard to do because um, you have to have a lot of heart transplant a lot of heart transplant patients randomized into a study to be able to have statistical power. So you're kind of limited with the amount of patients you can recruit at one time, which explain why it's hard to have very good prospective studies. But that's what would need to be done. But also, I want to reiterate, we'd have to also look at induction versus no induction first.
Thank you.
I don't know if there's any other questions.
I guess I have another question. So you mentioned how in some of your groups there were differences in the proportion of men versus women. And so I was wondering if you have any thoughts on specific patient populations that might benefit most from weight adjusted dosing. And I guess if there are any potential risk for changing to a more weight-based dosing.
I think the first part question, who would be most benefit of a weight adjusted dosing? I think that it would be everyone really, because our patients that come in with different weights, you really want to be careful not to overly immunosuppress, which then leads to a lot of complications. Maybe something I didn't put enough emphasis on, but if you have the fact, if you over immunosuppress and you develop infection, then you're stuck with holding your immunosuppression therapy, and then you're stuck a bit leaving the patient uncovered with immunosuppression and at risk of an acute rejection. And then if you have to deal with both, that really complicates things. So we really believe that everyone should have weight adjusted dosing. And then having a difference between men and women, we know that women, the body composition is different from men. So weight adjusting dosing just helps give us that more personalized approach to induction therapy for them. So that's what I think is really important, is to consider that just giving a fixed dose to everybody is maybe not the best way to go, specifically when the literature is really indicating that we should go weight adjusted. There was a second part to your question. If you could just remind me the second part of your question.
I think you answered it, the risks or benefits of the weight dosed RATG.
So
But yeah.
So the ways dose is just making sure we're not overly immunosuppressing our patients, specifically when you consider that half of the heart transplant programs in the world don't even use induction therapy. Um, you really want to be careful here of not overly immunosuppressing. So I think we're going more towards lower dosing seems to be better. But again, what's the number? Is it 3.3? Is it 3.5? Some studies or some centers are doing 3.5 for patients who going in heart transplantation with a really high risk of infections, or who are infected and that you have to just give them their heart. So I think we're going towards lower, but in the Montreal Heart Institute, based on our analysis, we're probably going to change our protocol very soon to a weight adjusted dosing, with being more on the lower side of 4.5.
Thank you.
I have a follow-up question to that. You just mentioned that you're saying the treatment right now don't use induction-based RATG. What other induction therapies is used? Like what are the treatments that are happening right now?
So it's maybe I wasn't clear on that. So you have, let's say, half of centers will use an induction therapy with our ATG or basiliximab. Our ATG seems to be superior than basiliximab in terms of like the acute rejections. So what other centers will do is they'll just put in the maintenance therapy really rapidly. So you give the heart, you start your calcineurin inhibitors, you give your antimetabolites as a azathioprine or mycophenolate, and you give corticosteroids. Our experience at the Montreal Heart Institute is that yes, this is a good approach and it seems to work because half of programs are doing it. But our big limit is really that when you have kidney injury associated with the graft, why we like to have our ATG is that it helps us kind of defer um, some of our nephrotoxic immunosuppressive drugs, and we give a chance for the kidneys to recuperate, and then we put in our maintenance therapy. So it just gives us that buffer zone because now we know that the patient is being properly immunosuppressed with the RATG. That's kind of like our experience. I don't know how other centers, what their data is, because there's not a lot of data that's out there that's comparing it compared to RATG. So it's hard for us to know what the real answer is in terms of induction therapy or no induction therapy. So it's a hard question to answer, but that's something that has to be addressed, I think, down the line. But we believe that RATG helps our patients because we can kind of delay that nephrotoxicity from our drugs and let their kidneys recuperate, specifically with a big portion of our patients necessitating some dialysis around the surgery.
Thank you.
We're just gonna take a last call for any questions. Take a look in the chat for a few seconds. Okay, awesome. So again, thank you for the excellent presentation, Dr. Bebawi. And on behalf of the CDTRP, thank you again for presenting. So if anyone has any additional questions, comments, or suggested topics and speakers, please contact Erica Croft at ekcroft@cdtrp.ca. And again, thank you everyone, and enjoy the rest of your day.